Hello everyone and welcome to The Nutshell. In this week's episode, we're speaking with a very inspirational doctor that we met last year at the Lifestyle and Nutrition Conference in London. Dr Saima Ajaz is a medical specialist in the field of liver disease, hepatology, and a lifestyle medicine physician, and her work intersects clinical medicine and research within the Institute of Liver Studies at King's College Hospital. She is also an Honorary Senior Clinical Lecturer at the School of Immunology and Microbial Sciences, and if all of that is not impressive enough, she also had the time to set up LIVFIT, the UK's first patient support group for metabolic dysfunction-associated steatotic liver disease, where lifestyle medicine is a key focus. But we'll come on to that in this interview, I'm sure. So welcome, Saima. We're delighted to have you on the podcast.
I'm really, really honored that you have invited me and I'm able to talk to you.
Thanks, Saima. Today, we're going to be speaking about liver disease, in particular, focusing on metabolic dysfunction and liver disease. So perhaps you can set the scene and remind us about the prevalence of liver disease, and perhaps within this, how much is related to metabolic dysfunction associated steatotic liver disease. Now that's a mouthful, the new acronym, the MASLD.
Liver disease is currently on a massive rise world over, and in UK, it's the third leading cause of premature death. Worldwide, it's nearly 2 million deaths per year, which is 1 in 25 deaths annually. It's a huge burden on economic as well as patients' health. Metabolic associated steatotic liver disease, it was ignored quite a lot previously, and I think we don't still have the accurate data of the prevalence. Currently, globally, it has been identified the prevalence is around 32% average, but it depends on the geographical locations, but the range is from 24 to 28. But this is the prevalence while we are not actively screening. So if we are screening, and in many of the countries, screening programs are not available. In UK, again, because this parallels the obesity and diabetes epidemic, 1 in 3 young adults do have MASLD. The current prevalence of people being overweight is around 63% or 64% in UK. And it has been forecasted that, it's going to increase significantly, more than double in the next 15 years. Again, it's the leading cause of liver transplantation in women and the second leading cause world over for the liver transplant in both sexes. So it's a massive burden.
And until quite recently, it was just called something simpler, wasn't it? Non-alcoholic fatty liver disease. So as clinicians, we'd see fatty liver on an ultrasound, and then we'd ask the person if they were a drinker or run some tests for hepatitis viruses, perhaps. And if we had a good history that they hadn't been drinking heavily and there was no other cause, we'd call it non-alcoholic fatty liver disease. So why the name change?
So for 50 years, we have been calling it NAFLD or non-alcoholic fatty liver disease. There has been a lot of discussions ongoing, and a lot of these discussions were actually being held because the patients, although it's non-alcoholic fatty liver disease, patients were still stigmatized. They were still labeled as something related with alcohol, although the name signifies that it's not related to alcohol, but because the alcohol words come in it, whenever we used to meet people, they say that, they don't want to come forward because all the liver disease are thought to be related to alcohol intake. Now, MASLD has been more, it signifies how the disease occurs or the pathogenesis, because definitely it's metabolic dysfunction associated. It's part of the same spectrum, which is all the chronic metabolic conditions. So it's a liver manifestation of the metabolic syndrome. But it's parcel of the whole, diabetes, obesity, hypertension, high cholesterol. And now we have changed the definition. I think we are getting used to it, but as clinicians, it makes more sense because it is a metabolic disease. And definition, so let me just give you currently how we defined MASLD. MASLD is extra fat in the liver with any of the 5 cardiometabolic features, which are increased BMI, pre-diabetes, diabetes or on treatment, high blood pressure or having hypertension on treatment, and lipid abnormalities, which can be high triglycerides or a low HDL. The management becomes much easier because the management is not just removing fat from the liver, it's how we manage the rest of the cardio-metabolic features of the patients.
I mean, this is something that we were sort of struggling when we were thinking about what to talk to you about today, because we have been meeting patients that are not obese and are being found to have fatty liver with no obvious cause. So is it fair to say that it's not always related to being overweight?
Definitely. So we call it lean MASLD, and this is a huge proportion. And again, it varies. It varies with genetic susceptibility, ethnicity, and again, the range is from 3.2 to 34, a huge range. But in some ethnicities, it's much, much more highly prevalent. And visceral obesity, as you understand, it's something different from the normal obesity when we talk about, because we talk about, although again, there's a lot of discussion as is BMI a very accurate parameter, but just for sake of simplicity, we say that, yes, it is. People can have normal BMI, but they still have more fat accumulation around the organs. And this is when we call it visceral obesity. And the simple test that you see in the practices, and we say it, is like, if there is more abdominal fat, or like, the waist hip circumference ratio is increased. So these patients sometimes maybe even having normal measurements and still have fat accumulation, which is related to genetics. One of the genetic predisposition is with the PNPLA3 gene. But then again, there are a lot of other factors, insulin resistance, other cardiometabolic features, which result into accumulation of fat. So definitely lean people can have fatty liver disease. Management is a bit difficult. Patients already believe they are quite healthy. If the patient looks slim and we think that it should be perfectly fine. But actually, there is data shown, and the management is similar, which is reducing 3 to 5% of the body weight and moving more to healthy food habits, which is plants, grains, fibers. Maybe they have normal BMI, but the eating habit are not so healthy. So there's a lot of things that can be done.
So you think even in these people that are thin on the outside and they've got the fat around the liver, even they will have some lifestyle modifications that can benefit them. They won't be stuck just because of their genetics.
Definitely. And this is based on the data. There's a lot of papers, publications coming, especially in the South Asian population where it is highly prevalent, how to manage these patients. Based in South London, I would say I see less of these patients. 3 to 5% of the patients I see do again have. But again, are we not screening those patients? Are those patients not coming? They are not being seen in primary care because they feel healthy. 90% of the liver diseases, based on the British Liver Trust, they are preventable. So 90% preventable, not screening, silent disease. This means that by the time they reach the tertiary care, they are quite advanced. And I think in primary care, unless they have some symptoms or you check it for something else, like, do an ultrasound for something, abdominal pain, or doing some tests, you find liver function tests are abnormal, then you will think about the liver disease.
Yeah, that's certainly true in working in GP. It sort of pops up rather inconveniently a lot of the time. We often ask at this point about what is the influence of something like the microbiome in liver disease. And we are aware of the limitations, I guess, in research, but how is it looking in terms of the influence of something like the food we eat in terms of the microbiome on the development of fatty liver?
I think in the liver area, we are one of those specialities which has really advanced in microbiome because we have done a lot of work in the gut, liver, brain axis, and the microbiome forms a part of it. There is less literature and less long-term trials done in this area. We know there's a link because fatty liver disease is accumulation of fat in the liver. If there is leaky gut, as we call it, if dysbiosis in the gut or the bacteria simply are not functioning in a healthy way, they can be leaky gut, and the LPS or the lipopolysaccharides, they are released and they go directly to the liver where the fatty liver pathway, again, then the short chain fatty acids, they again go to the liver from the gut. So And that's how, the fatty acid metabolism, which interestingly, I should have mentioned this before, 500 of the body functions occur in liver. You know this. It's like, it's the most important organ, along with, I would say, heart, that, allowing the body to function properly. And all the metabolisms from glucose to fat and everything, they are occurring in the liver. So anything which affects the circulation, especially the gut microbiome, it directly affects the liver function. A lot of literature is coming. Even in the treatment, we are getting a lot of the role of prebiotics, probiotics, and how it's going to influence. It is an evolving field. I think it will be very interesting to see when we have some treatments for the MASLD where, like, these supplements or these things have a role. I think they will definitely have a role because it's part of the cardio-metabolic spectrum.
Because on that, obviously on this podcast, we're all about you're better off eating a whole food plant-based diet for so many conditions. But then people always ask us about shortcuts and, can you have things in a more concentrated form in a supplement? It was only the other day that something popped up, and it was a hepatologist telling listeners on a podcast that he was taking a supplement of something called resistant starch. So a type of fibre. Is that what you're alluding to there?
Working in a transplant liver unit, we do a lot of clinical trials. And because of the clinical trials, we tell our patients not to take any herbal or any other supplements, because we cannot then offer them anything. And just let me put a brief background why we have to do it. Currently, there's no treatment for MASLD. Only one approved drug, which was approved this year, and we will talk about it later. So all the management has been holistic. All our management has been based on lifestyle medicine. But then if we have to offer them some medical treatment, it has to be clinical trials. So we are a bit, I would say, even I'm a bit reluctant to give any advice on supplements, because then I cannot offer them any clinical trials. But having said this, the things which we know are healthy and plant-based, and they have already shown a lot of influence, and then there's a lot of data. And the current guidelines, we will talk about the guidelines, I think a bit later, but it's Mediterranean diet. So, Mediterranean diet is all mostly plant-based, fruits, vegetables, and nuts and all these things, olives. So these things do have a role. I would say yes, supplements which will affect and improve your gut microbiome, they will have a role. And again, some of the herbal medications and antioxidative, anti-inflammatory, they will benefit as they benefit any other chronic conditions. And a lot of data has been coming out in food supplements: ginger, garlic, turmeric, all these things, apple cider, they all have quite an influence. Coffee. So in, for MASLD, it's quite recommended to have at least 2 to 3, based on long-term research, to have coffee. So, coffee beans and all these things do have influence. So it's like having the balance, what you are doing in the practice and what the patients can actually do to maintain their own healthy life.
And obviously, something that you do for one disease, as we've said, it often helps with another disease. But can you talk a bit more about what the link is between MASLD and what happens when we get insulin resistance and then progress to pre-diabetes and diabetes?
So we have always known this link, and now it's a part of the definition. So, if you have pre-diabetes, diabetes, insulin resistance, and have a little bit of fat, now it's like, part of the spectrum. We know that based on the data that 70 to 75% of the patients who have diabetes, they have MASLD. And the prevalence in diabetic population is very, very high. And the reason is the pathways are the same. So even the drugs which are coming for the management, they are targeting the same pathways which are being targeted in diabetes. So because as I said, it's the liver manifestation of the metabolic syndrome. So anything which is going to cause chronic stress, chronic oxidative stress, it will going to affect insulin resistance, and it's going to affect fatty liver. Having said this, again, glycolysis and the glucose pathways and the metabolism occurs in the liver. It is the major organ where all the metabolic pathways are occurring. When there is a fat accumulation, we call it medically steatosis. But if it's associated with inflammation, where if we do biopsy, in that case, we will say that the cells of the liver are inflamed, they are ballooned, and in the blood test, the liver function tests are deranged. So we are seeing the manifestation of the inflammation. Then it's called MASH. Now, if this remains for a longer period of time, it can lead to stiffness of the liver or fibrosis. And again, that has stages from F0, F1, F2, F3 to F4, which is the last stage of cirrhosis. For the ease of simplicity, we describe it as a linear way, like, fatty liver, inflammation, fibrosis, end stage. Clinical practice, you don't see patients like that. There's an overlap. They may be progressing, very fast forward to the fibrosis stage, or they may be if they change their lifestyle, changing to totally, normal without any fat and without any inflammation. So in clinical practice, there's an overlap of these conditions. And all these conditions or stages are related to how you're controlling your the metabolic parameters. So if diabetes is very well maintained, you will have improvement in the functions as well. So one of the main features of the guidelines which are out there is when the patients have metabolic steatotic liver disease or MASLD, you have to very focus on the other features, basically high blood pressure, diabetes, abnormal lipid profile. So the link is strong. It's the same disease. It's just represented in different way, and the patient population is the same. And again, I think just to mention the GLP-1 drugs, they have they have been approved for diabetes, but they are in clinical trials for the MASLs. Again, the pathways are the same, and that's why we will have a combination of these drugs.
Going on from that, because obviously you've mentioned you've got the F1, F2, F3, F4, that somebody might be graded if they actually get to the fibrosis stage. As GPs, when we have to tell someone that they've got fatty liver and we're starting that process of assessing where they are with it, right up front, I've heard that not too many cases are actually going to progress to full fibrosis and then ultimately liver failure or need a transplant. But what is the percentage of cases that might actually do that? Do we know that?
I think we will, in the next few years, we will have much more accurate data, but there is data present. And it shows fibrosis is very slowly progressing. So if you have one stage of fibrosis, it takes around 10 years to move to the next stage. Now, this is in normal individuals. What we are seeing in practice is that I see the transition young patients, 19, 20, 22 years old, with F3 fibrosis. They didn't have this much time that it has taken for them to reach, F2, F3. And we do in peds, we do a lot of biopsies in the liver, and we know related to MASLD, there is a lot of patients who have advanced fibrosis. How fast the progression can be quite variable. And because we don't have data, we are still going with the old hypothesis that it is slow. I'm talking about young transition patients. I have a lot of 30 years old, 40 years old. They have F3 to F4 fibrosis. I think there's a lot of more data which will be coming out because it is highly prevalent that we see young people with having advanced fibrosis, which didn't have so much time that, it takes. Suppose for F3, then if we go with the stats, it will take around 30 years. So how we are having 18, 19 years old with the fatty liver disease, having F3 fibrosis. There's the study done in UK was that 1 in 3 young male adults have early stage MASLD and with some degree of fibrosis. All these data are coming out. So I think it will be an interesting next few years when we see actually with screening abilities what is the progression of disease. The gold standard is liver biopsy. We do have non-invasive tests and imaging techniques. But again, if we use the guidelines recommend FibroScan, ELF score, how many these screening capabilities are available in the primary care? I think you would be more, comment on that. But I know, especially even in London areas, we don't have FibroScans available in the primary care. mostly, in the most cases, apart from where we are doing some research projects.
I think the fibroscan, it's certainly familiar to you if you've been diagnosed as having alcoholic liver disease, and they do that in the community. But I think what's much more sort of almost scary when you talk about the rate of progression potentially in some individuals to fibrosis is, what is our responsibility as GPs in monitoring if somebody has fatty liver changes on the ultrasound? So, we do things like we do something called a FIB4 score, where all we need are some, a full set of full blood count results and obviously some parts of the liver function test. So it's a blood-based test. But I don't think that all of us are really sure that we're really checking things properly when we do that, or we're not really sure how often we should be doing, say, the FIB4 score for progression, and at what point we should be saying, actually, no, you're someone we should hand over to a specialist because you might be more increased risk due to genetic factors, for example.
I'm really very glad this year because a lot of interesting things have happened for the MASLD in this area and for the EASL, for the European guidelines. We have first time the guidelines which have focused on the lifestyle. So in the guidelines, we have been given details about how to manage from the lifestyle factors. Previously, and I will just give you an example, 2016, and those guidelines were ask the patients to reduce weight, and then you see them after 2 years, and the same, I think it was mostly for the primary care. Now we have a guideline for screening as well. And that is as you just have a consultation with the patient, see that they have predisposing factors, which we have discussed again, diabetes, prediabetes, obesity, high waist hip circumference ratio, or any of the predisposing conditions that the patients have. And you do simply, as you said, the FIB4 test, which is the ALT, AST, platelets, and age. If it's less than 1.3, you manage in the primary care with repeating FIB4 every 1 to 3 years. If the range is between 1.3 to 2.67, then you actually pay a lot of attention on the other cardio-metabolic conditions and try to control blood sugar, control blood pressure, have lipid-lowering drugs, all these, and repeat any of the imaging, fibroscan, ultrasound, whatever is available, or ELF test, which we will talk about that it's not available in most of hospitals even. If that is, again, fibroscan is more than 8, you refer directly to the hepatology services. Or if the FIB4 score is more than 2.67, they have to be referred to the hepatology services where we do all their screening. So it's the whole liver MOT sort of test. We rule out immunology and viral serology and all these things. And we manage the patients and maybe advise if all the scan shows a liver biopsy, which is the gold standard. So I think it's important what we are saying, it's that FIB4 less than 2.67, unless the fibroscan is more, it has to be managed in primary care. So a lot of responsibility comes over primary care, and this is just because we don't have the capacity, because it's such a highly prevalent that we see all these patients in the tertiary care. We already have quite advanced liver disease. But then if you don't have fibroscan and you don't have the other imaging things available, you're again referring them to the tertiary centers. So there has to be there are a lot of pathways. I think each center, hospitals, and they have been published, but now they have made it simplified that, any imaging, and I've not talked about the ideal imaging, which would have been why would we go for I'm saying this, although I know the gold standard is biopsy. Why cannot we have MRI based or those sort of tests available for these patients instead of just going for an interventional biopsy test? But we know that there's a lot more to be done in the capacity of the system where we can have these tests available. But even simple fibroscan, ELF test again, all the guidelines, NICE guidelines, EASL guideline, ASLD, we recommend this test. But even in the tertiary hospital, we have ELF test available at King's this year. So previously, we didn't have these tests available. So I'm very sure there are very less centers. There is a data published that I think only 4 to 6% of the centers have ability to do ELF test.
I've not heard of this test, Saima. Is it what sort of test is it?
It's a blood test,
Oh,
but
okay.
it's an expensive test, so it's not available. Although guidelines suggest to have it because it shows if the patients have fibrosis. So it's a very good prediction for the fibrosis level.
Yeah. Thank you for that. I think that's really clarified for me because, like Claire said, as a GP, I'd do a scan and diagnose fatty liver, or MASLD as it's now called, and then sort of not knowing where to go from there. But I think it's very clear now that the FIB4 score is a very useful tool and one that can direct us in when to refer. Clearly, though, we want to stop the progression rather than have to refer to you as specialists. So, I mean, I guess as you sort of hinted on it before, previously we'd have the diagnosis and we'd say to the patient, oh, well, try to lose a bit of weight and that will help. But I don't think that's very satisfactory. Yes, weight loss is important, but how would we give a bit more specific advice? Or, what sort of diet? We love talking about nutrition on this podcast. What sort of diet should we be recommending?
So first of all, I think we have never treated obesity as as a disease or as a condition. We treat it as a normal variation, and it comes back to healthcare professionals as well. We have been scared to talk about obesity. I will give you my example. I had to do a whole course to how to talk to people who have high weight or are slightly overweight, because it's a very sensitive issue. You have to, even when you have to tell patients. So when we were creating the LIVFIT group, we had the first meeting. This is 6 years back, and the patient said, our main complaint is when we come to the practice, or when we come to your hospital, or when we see clinicians and your colleagues, it's a sort of a judgment they pass to us that it's our fault that we are overweight. And no one wants to be overweight. Who wants to be overweight? So one thing is very important, how to develop the relationship with the patients, and then you're able to guide them. And when we're talking about lifestyle medicine and we're talking about nutrition, as I mentioned, there's only one drug which has become available this year, only in US, not in UK. We don't have that drug. That's only for different stage of fibrosis, not for MASLD. It's all comes back to what are the lifestyle changes or nutritional advice we have to give them. So I would say, first of all, we need to have a relationship with the patient. There's a lot of advice already available. If you go on the internet, there would be programs, there would be apps, there would be things which are available. When they are coming to you, you're in a position that you're sitting, that you can guide and you can mentor those patients. I think that's the role that we really have to use, because and that has to be based on the data. So when you give the numbers, I will just give you an example. FIB4 high, FibroScan high, and you tell them it's not a normal condition. You have an issue, but it can be reverted back. Currently, the guidelines have mentioned all the nutritional parameters that should be done. And they have based only those parameters where long-term research was conducted and we had the data. So Mediterranean diet, now it's part of the guidelines that you do physical activity, you do Mediterranean diet, you cut down saturated fat. We haven't commented in the guidelines. It has been mentioned, but not recommended because data was not strong enough. Intermittent fasting. Very interestingly, when the guidelines were published, the biggest research, which was to follow up the patients on intermittent fasting for the MASLD, they released the data afterwards because the study wasn't complete at that time, and which looks very promising. So intermittent fasting, having things like coffee, which are not in the guidelines but mentioned because research is ongoing, and we have this data, more fiber, more plant-based, more of the foods which are considered healthy, more fruits and vegetables and grains.
Lovely, yeah. I'd like to ask you a few bits on what you've mentioned there. So let's start with intermittent fasting, since you've mentioned it. Is that just calorie restriction because you're eating less hours of the day, or is there actually more to it than that, hormonally or metabolically?
I think it's a combination of both. So the study which was done, it compared the intermittent fasting with low caloric diet and also with low carbohydrate diet. The results were much, much more significantly higher in intermittent fasting. The resolution of MASLD was much higher in that. So caloric restriction, definitely, because there was weight loss and there was improvement in the group which were on calories restricted diet as well. Scientifically as well, it makes sense that any restriction or any decrease in the amount of calories you're taking, it's going to affect your weight and it's going to affect all the cardiometabolic features. But what happens in intermittent fasting is your basal metabolic rate increases as well. So that's the main thing which really helps, and it detoxifies. And when you eat again, it should still be healthy, because your aim is to reduce a condition, to recover from a condition. So the efforts have to be more. Most of the patients say that when they come, we did the intermittent fasting, not showing so much effect, because in the time that they are eating all the food which we will not recommend them to eat. So if it's a healthy food, if it's nutritious, in the intermittent fasting, your basal metabolic rate becomes much, much more efficient. It takes much more time to break down complex food
Yeah.
particles.
So it's a good strategy, but it's obviously not a ticket to eat whatever you want in the time that you are eating. Fair enough. And what about saturated fat? You mentioned it a couple of times. Reduction of saturated fat is really important. To us as professionals, it's pretty simple. The evidence is there. The literature dates back many, many years, and the Mediterranean diet features a lot in various recommendations. People do get conflicting advice. Eat more fat. Saturated fat is okay. And so some people will follow a low carb or a keto approach to weight loss. Are there any risks with that?
So it's again an area where there's a lot of conflicting opinions. Sitting in a clinic when the BMI is above 40, when they have liver conditions, I wouldn't mind anything which works for the patients in reducing weight. But again, having said this, all the diets which are more ketogenic or fat, they are not meant for long-term sustainability. My approach has always been, it's the lifestyle change. It is something which you have to change for your life. Otherwise, it will be what we have been seeing in obesity. It's a yo-yo sort of relationship. You lose weight, you go on a ketogenic diet, you lose 5 to 6 kilos in 1 month, you stop it, because it's not even healthy to do it over a longer period of time, and you again develop the weight. This is not going to work when you have a condition which actually needs resolution. So then it has to be moving to healthy lifestyle. I will give you an example. If you go on a keto diet, things that you can eat, maybe some people would love it: butter, cheese, cream, steaks. Do you think over a long period of time it will be very, very beneficial for the general health? It wouldn't be, and it's not sustainable. So in that, I think slowly what you have to tell your patient is, okay, you have done it, you have done the keto diet, good, you have lost so much, now let's become more plant-based, let's become more this, and slowly move them toward that area.
Yeah, we agree. It's definitely more sustainable and healthier for other organs, isn't it? The heart and other things. Great. And moving on to exercise, is that important?
So definitely. And again, we realize that, doing the amount of exercise to lose weight is quite high and strenuous, and most of the people don't. And we think that, doing this much exercise, we are just going to lose weight. It's not for just losing weight. It's just maintaining healthy lifestyle. It's important for your cardiac, outcomes. And with age, so mostly the patients I see would be mid 40s and 50s. You need to have the strengthening exercise, making a different routine as compared to if you're just doing the cardiovascular exercise. So there's a lot of combination, and it does work. And again, in the guidelines, we have recommended the WHO for the MASLD, at least 30 minutes, 5 days, you have to do exercise.
And what about other lifestyle factors, Saima? Is there any evidence that stress plays a role, for example?
Yes, so definitely stress, sleep, avoidance of harmful other substances, emotional connectivity. Stress, because it's part of the oxidative stress. Anything which increases your stress factors, it has a direct influence on your cardiometabolics. We have known this relationship for diabetes for so long now. Now the data has come out for MASLD as well, that directly linked to your stress levels. So when we are giving an approach, I always say that it's not just a diet. nutrition and exercise. It has to be all the 6 parameters, and emotional connectivity, which we miss again. Like, I think people, why they turn to eating all these things. This is comfort food eating. And it's a vicious cycle. You gain more weight, you become more isolated, your self-confidence decrease, you again turn to harmful substances or to the unhealthy eating habits. If you have a support system, if you have a system which is actually helping and guiding you, and I can tell you, working in this field, 100 of stories, how just like, being there for the patients, having this group formed, how life changing it is. And I think in primary care, you do group consultations and you have park run, and it really is emotional connectivity. Sport is so important.
Absolutely. I think it's an important condition to raise awareness of amongst clinicians and patients, and I think that will make a difference to the interventions. Something like diabetes or other metabolic conditions are talked about a lot, and yet liver disease in the context of metabolic conditions are probably less discussed. I know you did a study in some participants in South London who already had diabetes, but were not even aware of what fatty liver was. Can you tell us a bit about that study and what it showed and how we can raise awareness?
The main aim was, when you may want to make some changes, so working in a tertiary center, seeing all these patients and listening from them, I knew that, lifestyle factors, lifestyle hub, lifestyle multidisciplinary clinic where GPs, tertiary care, we all see them with nutrition, that would be an ideal thing to have in community or in the hospital. Healthcare providers talking about it and raising awareness. Now, whenever you have to do something like this, it comes back to the funding, and it comes back, where's the data? So the idea to do this study was, let's see, based on the screening capabilities that we have in our liver unit, let's go out in South London, which we have lot of deprived population, multi-ethnicity, and see the awareness. We did a lot of things in the hospital where we were having questionnaires, and we found out even our healthcare professionals, the awareness about fatty liver disease was around 38%. Now, I'm not talking just about the doctors, it's all the workers in the hospital. So if that's the case in a big hospital, what about the population? So we went into high-risk population. So let's start screening them. And the project is still ongoing, but we have published the data. And in these patients who had diabetes, the average BMI was 32. Only 69% of them thought they were obese. So, again, coming back to same thing, BMI of 32, and thinking lack of awareness, like how obesity prevalence is. The fibrosis, steatosis was high, but we know that it's around 70%. We had a bit lower because I think it was very well managed diabetes care team, so it was around 59%. But fibrosis, advanced fibrosis with FibroScan above 8 was 28%. Now, these are patients who don't have any liver disease and they have liver fibrosis. It's a very interesting study because we have gone deeper into the awareness. Highest was 49% in Caucasian population. Rest of the ethnicities, it went to even like less than 10%. So, more deprived, more lack of awareness. And having done this study, I'm just going to mention just another study, which I have not published. And the data is based on 25,000 FibroScan that we did at King's in the last 6 years. High fibrosis values were directly corresponding to the IMD, index of deprivation. So the more deprived the patient's group, the higher degree of fibrosis. And it's directly related again to the ethnicities as well. So it's a huge area where we definitely need to focus. So these patients are coming to centers where, at least for diabetes, they're getting a dietitian, a nutritionist, and everything being available. And still, I think they were not doing so. They were not doing exercise, which was the recommendation. Their food mostly still consisted of high GI food. And I will like to mention that socioeconomic, constraints come. We have always thought healthy eating is more expensive. So what we have started doing is teaching patients how to actually cook healthy food, which is very cost effective.
Brilliant. I was going to ask you about what barriers we need to overcome, but perhaps you can discuss that with Claire when we talk about your LIVFIT program. Before we go on to that, can I just ask you, I suppose, to summarise things in terms of guidance? You mentioned there are some European guidance for screening and management. Where's any particular guidance you would recommend that clinicians use when we're managing patients?
The importance is definitely having the lifestyle whole package, advising them as a whole, all the 6 parameters, and having a good control of rest of the parameters. I think another important thing to mention is the drugs which are available for diabetes, the GLP-1 analogs. We know that these drugs have been approved for diabetes. If your patients have high BMI and they have liver conditions, think about management of their diabetes with these drugs, because they will help reduce weight. And we just got the data that how effective it is in reducing fat in the liver. Fibrosis stages is still being under study in clinical trials stage 3. So something to think about, that if the patients have one thing where you can give the drugs which will actually help in weight reduction and they have fatty liver, maybe it's useful to give them those drugs.
Okay. Well, I suppose since we're talking about drugs, maybe we can ask you hinted at the new drug that's not yet available in the UK. Can you tell us a bit more about that?
This drug it's from a company called Microbial, and it's rismetrone. We have done the clinical trials here. It has been approved in US by FDA to be the first drug for the MASLD to reduce fibrosis. But because it's an expensive drug still, because it was approved this year, it has not been approved for outside US yet. So I don't know what will be the time frame when we will have available, but it's a groundbreaking thing that we have first drug being approved. Having said this, clinical trials are always an option. If they have advanced fibrosis, in the whole UK, we do a lot of clinical trials in liver, either waiting for a drug, or is there an option of giving them maybe in a little dose, or maybe less percentage of patients, but the options are there. But yeah, in terms of drugs, there's way less options currently available.
So it's something for more advanced fibrosis, maybe, and somewhere down the
It has
horizon.
been approved for F2, F3 fibrosis. So it's not for advanced fibrosis. The trials are still ongoing. So it has not been approved for cirrhosis. But at least we have one drug. When one drug comes, usually a lot of other drugs follow, and maybe combination drugs.
I'd be interested to know, though, what are your thoughts about treating what is essentially a lifestyle-related condition with medication?
So it is a lifestyle. Definitely, it's a lifestyle related. The data is that if you have fatty liver disease, just the MASLD, if you lose 5 to 7% of your body weight, you can have a resolution. Okay. But if you have fibrosis, you need to lose around 7 to 10% of the body weight. And that can improve at least one stage degree of fibrosis. Having said this, it's very, very hard to lose weight and to make changes. When you're asking someone in the middle age who has struggled throughout their life with the lifestyle changes, it's it's a battle which is very hard to win. So if the drug is available which can help reduce fibrosis, definitely you want to save the liver function. But the drugs go hand in hand with the lifestyles. Even with the drugs which are coming, GLP, for weight management, it is recommended that you change their lifestyle during that time. So lifestyle has to be the parcel of the whole management.
Yeah, that makes sense. So going back to lifestyle and what we love talking about, I think Claire wants to ask you a little bit about the work you're doing on this.
Yeah, I just wanted to ask you to tell us about LIVFIT.
I started this clinic, and I was hopeful I will have a dietitian, a nutritionist, a physiotherapist. Combined for the lifestyle, you need all, sort of team to be there. And obviously, it's difficult to have this sort of funding to have a team just for one clinic and for a disease which is very, very highly prevalent. So I didn't have. So at that time, I did my certification in lifestyle medicine. Now, again, because the clinics are overbooked, just to give you an example, my clinic is overbooked for the next 1.5 years. to maximum capacity. So if I have to give some advice and I have to see the patients, how can I see them and guide them? It's not possible. And then if they're overbooked, you have a time limitation. I changed the format of the clinic, but not 10 minutes like in GP practice. I have more time, but still a lot of advice to be given. So I realized it very earlier. This is not going to work. So what we will do, I had a group of patients. First I did a survey. They were all keen to have this group. We had the first meeting. Patients were on board. We started without any funding. We started having every 2 months with the ethics and approval patient support group in the boardroom and lifestyle experts. As you know, you're working in the same area. There are people who just want to give something, their knowledge, their time, and everything away. That's what I love about the people working in this area. So all my lifestyle experts have been giving for last 6 years, world leading authorities coming for this patient support group and giving them advice on different topics. So we cover from sleep, nutrition, plant-based, emotional connectivity, stress management, exercise. We have had physical activities guiding the patient that, even if you have arthritis or some issues, movement is so much important, and guiding them about the physiotherapist, lot of information. And what really helped was that patient group, which is called LIVFIT, became really evolved into a position when our patients have been presenting at international forums. So this year at EASL, our patient was giving the biggest talk in the patient's perspective. They have represented in International NASH Day, Global Liver Initiatives. So they have become speakers, they have become leaders. And it really changed the MASLD area in our trust. At least we had just one clinical trial or research study ongoing at that time. Now we have delivered, with the help of patients, around 50 clinical trials, because they understand how the importance of research and things are. So they are leading it. They are PPI initiative. They have become NIHR research champions. And I think the thing I'm really proud of my patient group is that our patient got training for the Patient Advocacy Academy in Washington, D.C. on fully funded scholarships. And we are now starting at King's with the GLI, the first initiative of Patient Advocacy Academy. So we are training patients to become advocates who can actually then give FDA, the European Commission, the guidelines, how patients want their management to be. If they want the lifestyle to be part, it should be a part. If they want non-invasive tests, it should be what the patients want. And not coming from our end, what is more convenient, but what is actually beneficial to them.
Wow. So does that mean that this kind of approach, it goes beyond where you're working? Is it available in other hospitals as well?
So this group is currently available. LIVFIT is available in King's, but we have kept it open. So, anyone can refer patients, and I have not even kept it for the patient. So, again, the emotional connectivity, it's the family, it's the whole changing of the whole, we kept it so open that they can bring anyone. If they're coming to King's, they can bring friends, they can bring family. And we now get referrals from outside London as well. So patients join and they come here for these meetings outside London as well. But now what we are starting is going to be the whole UK thing that, we will involve slowly, that we have patient advocates who can come here, get their training, go back and start their own groups.
Right. Yeah, that's so important. This accessibility thing, if somebody can't travel, do you recommend any specific tool or app that they can do online?
So for the LIVFIT, we haven't obviously done it. We have done it during COVID on interactive forums on doing the webinars and things and patients joining. Based on our feedback, our patients wanted to be present in live sessions. Many of them struggle in technology. And because this was not funded, we didn't have the resources to have that. But yes, we do guide a lot of patients. We have actually just had a booklet for the MASLD patients, which have resources to all the apps, not from the LIVFIT, but generally which are available in different trust, primary care, guiding the patients. What are the free tools which are available? There are a lot of tools available. There are so many now free tools available in NHS, in the primary care, and on the media that they can be used, and it's really very helpful. Just to give an example, we didn't mention that how important is drinking water as along with maintaining, like, most of the time you're hungry, you're actually thirsty, but this is the water app there, it just gives you prompts to keep on drinking water, I got a notification I haven't drank water. And these are all free.
I think I've got that water prompting app as well.
We guide them, but I wouldn't say at the LIVFIT forum we have been able to do it in a nationwide sort of campaign.
I just wanted to ask if there is a patient who was happy to share their story. Do you have any success stories or results from LIVFIT?
Yes, we have a lot of amazing stories, a lot of amazing people who, and we have actually made it part of the LIVFIT group that we are there. Anyone who wants to talk about their story and things, they are able to. It just motivates other people. I will just keep the name anonymized, but there was one patient who. So I will talk about two patients because I think talking about young patients is very important as well. So, a 23, 24-year-old who had a very strong family history of, liver cancer and has BMI of above 35, has fatty liver disease, based on biopsy, has F3 fibrosis, became really involved in the LIVFIT group. He has really changed all his lifestyle and lost over a period of 2 years by just changing the lifestyle around 15 to 20% of the body weight. He has started a new job. His depression has gone, in a better without any medications, his confidence levels, his social interaction. He's going to the gym. So social interaction has increased. And then going to another age where is 60 years old, living in isolation, living in a council flat, just having the food which was microwave and that, drinking alcohol, having depression, on the drugs which are then again have effect on the liver as well. It took around 1 year to develop that rapport with the patient, and he has become one of the most patient leaders of the patient initiative. He has started working. Alcohol is totally cut off from his life. Weight is I think 15 kg less, and all the clinical parameters much, much more improved. So, they all look forward when is the next session. They have an aim now to make it much, much bigger organization than it currently is.
It's brilliant. I think that's really inspiring, isn't it? It's really empowering to know that even if you have a diagnosis, there are tools and ways to reverse it through your lifestyle. So that's really brilliant. Thank you, Saima. We're sort of coming to the end of the podcast, but we can't let you go without asking you what your healthy dinner is for your liver tonight.
So I today it's lentil curry, and it's maybe you have heard the traditional name. It's the tarka dal. So it's lentil, but it's cooked in a way with some spices and nothing else. Very simple to cook. Hardly takes 10-15 minutes, and it's with the naan bread. So it's very simple today.
That's the thing, isn't it? Lentils cook so quickly, but all the spices, does that take up some time? Do you have to sort of blend them, or do you just?
No. They are all available. It's life has become much easier that you can have all the spices. Nothing happens to the spices. So if the jar of spices is ready, which my always is, so it's just simply adding the ingredients in one go.
Lovely. So you knock up a dal in 15 minutes. I love it.
It's the simplest food. So I have a busy evening, so I've kept it very simple.
Saima, are you making your own naan bread?
That's one step too far.
I can make chapatis. I cannot make my own naan bread. Chapatis is from whole wheat. That's a bit, it's quite tricky. And I cannot still make the nice circle ones, but I can make a bit irregular. But yes, I'm good in making chapatis and parathas, not naan. That's too high technical for me.
Oh, I love a naan.
Do you make your own, Claire?
No. But any opportunity, you've seen me when we're out for dinner, Daisy. I'm the bread monster.
What's your dinner tonight then?
Oh, right. So tonight I'm actually inspired from having been out for dinner. I'm going to recreate something from I think it was a sort of Sicilian restaurant, but I used to love those. Have you ever made sweet corn ribs where you get a sort of a corn on the cob and you split it into 4 and you cover it in some Cajun spices, and then you can actually put them in the air fryer and put them with some, lime juice mayonnaise. Really, really lovely, but incredibly dangerous to make, because actually trying to split a corn in the cob into 4 is just, it's the sort of thing that presents to A&E like the avocado stone injury that, you don't want to be doing that. So I went to a restaurant and they did the same recipe, but they did it with baby corns. And they were delicious. So they just took the baby corn, put them in Cajun spice, put a little bit of oil on them, I think, to roast them up a bit. And then it was with the lime juice and the mayonnaise. So I'm going to do that as a starter. And then a really simple pizza, which instead of using a tomato base, you use like a butternut squash puree base, which has got just some garlic and stuff in it. And you use that over your pizza dough. And then you can put blobs of romesco sauce, I believe, I'm going to look this bit up, but I think it's just blended red peppers, some oil, some garlic. You put the blobs of that on there, and then some kale, and that's it. And it's a really delicious pizza. It doesn't need any cheese.
Sounds great.
I'm going to have that.
That sounds like the sort of pizza that I would have liked to have used when your kids are little and you're trying to hide the vegetables, and it's got
everything blended in blobs, but really colourful as well. So. Daisy, what about you?
Can I not share my dinner, but share a dessert tip?
Your breakfast.
I've got?
Definitely. Now we need the dessert. I'm already feeling hungry.
No, it's because I've got a slight obsession with this one recipe that I've done like 4 or 5 times now. So I thought I must tell Claire about it, or I'll tell you on the podcast. It came about because I was just really craving these like sort of, squishy cookie type things. And I looked online and there was this recipe that involved smashing up a banana, adding a cup of oats, and then whatever spices you like. So I love cinnamon. I put some cinnamon in it, and then just put the blobs in the oven. And 20 minutes later, you've got this really chewy, gorgeous oaty cookie. And when it comes out of the oven, just put some chocolate chips on top so it melts into it. And it's just so simple and nutritious. And I've got a really sweet tooth, so it makes it a little bit healthier, that I can have the odd treat that isn't always, bad for my health. So it's a sort of highly nutritious sweet treat for the listeners.
Mm-hmm. So just in the end, we just on the last session for the LIVFIT, we did healthy cooking for the patients. And the chef at King's, he's all plant-based, and he had just amazing recipe with the dates. And just overnight date with, and then having that date puree in the morning with the oats, cinnamon, and pineapples. It was amazing. Quick 5 minutes, and the cost was less than £2 for a whole
Amazing. Yes.
So you can have healthy, economical food. And the other thing was the dressing with the spinach, lemon juice, and olive oil.
Very nice.
Just blending spinach, and I've never done it, but it was such an amazing with chickpeas.
Yeah. That's the thing. You can actually cook some really simple but nutritious foods. It doesn't have to be complicated. So if you've got a banana and some oats, just mash them together and stick them in the oven. So we'll just end up by saying thank you so much, Saima, for your time and your expertise. It was really fun chatting with you, and I feel like I've learned a lot. But if people do want to connect with you or learn a bit more, or where can people find you? Where can they find the work that you're doing?
So I am based at King's, and I do have a LIVFIT email as well. I'm very happy to, give any guidance or share any publications or the data which is available. And it was a pleasure talking to you both. And thank you for having me.
Thank you so much.